Welcome to Module 6 of Mechanical Ventilation Basics, where we will delve into the crucial concept of pressure. Interpreting and managing pressure is not just a theoretical exercise, but a fundamental facet of modern mechanical ventilation. It guides patient care and ventilation decisions, affects patient safety, and influences outcomes. In this module, we will begin by reviewing and expanding upon the previous lesson on positive end expiratory pressure and the fraction of inspired oxygen, and dive deeper into functional residual capacity. The FRC, or functional residual capacity, represents the lung volume at which gas exchange occurs between breaths. Following the review of Module 5, we'll explore the range of matters relating to airway pressure, PAW. Airway pressure encompasses inspiratory pressure, abbreviated P control or P-insp, peak inspiratory pressure, abbreviated P-peak or PIP, mean airway pressure, P-mean, plateau pressure, abbreviated P-plat, and driving pressure, delta P. We'll examine the pressure waveform to drive home the learning objectives and continue our exploration of mechanical ventilation concepts and ventilation waveforms. We will not review pressure support in non-invasive ventilation in this module, leaving that discussion for an upcoming module on BiPAP. In the previous module, we explored positive end expiratory pressure, PEEP, inspired oxygen fraction, FiO2, and expanded flow waveform interpretation. By analyzing the flow waveform and comparing the volume inhaled to the volume exhaled, we learned how to identify breath stacking. Breath stacking, also known as air trapping or incomplete exhalation, occurs in obstructed patients or patients with poor lung recoil, like patients with emphysema. Air trapping can lead to hypoxemia, hypercapnia, overinflation of the lungs, volutrauma, and ventilator-induced lung injury. Carefully monitoring the patient and ventilator for evidence of breath stacking is essential for patient safety and favorable outcomes. Adjusting PEEP and FiO2 is a safe practice and the most effective way to maintain optimal oxygenation in your patients. As a healthcare professional, you can adjust the fraction of inspired oxygen and PEEP on the T1 ventilator. For most patients, initialize PEEP at 5 centimeters of water and FiO2 at 1 or 100%. Then, we gradually reduce the fraction of inspired oxygen, aiming to use the least supplemental oxygen and PEEP to maintain a saturation between 94 and 99%. Mastering the FiO2 and PEEP adjustment strategy is a critical skill that you can learn to ensure the best care for your patients. An upcoming module has more on titration and ventilator settings adjustment strategies. PEEP refers to the pressure in the lungs maintained at the end of expiration. Here, I have the PEEP set to 5. The green bar represents the PEEP of 5 centimeters of water pressure on this pressure waveform. If I increase the PEEP to 10 centimeters of water, the pressure waveform does not fall below 10, indicating the application of a PEEP of 10. PEEP keeps gas in the alveoli at the end of expiration, improving the functional residual capacity and helping to retain a larger surface area for gas exchange. The FRC, or functional residual capacity, represents the lung volume at which gas exchange occurs between breaths. Without it, the alveoli would collapse and gas exchange would cease. improving functional residual capacity. Patient positioning drastically impacts FRC. Avoid positioning patients supine. Maintaining the patient's head of bed elevated position at 20 to 30 degrees before, during, and after advanced airway management will radically improve the FRC. The upright position enhances lung capacity and promotes the expansion of the lower lung fields. It also improves lung compliance by reducing the weight of the chest and abdomen and helps the diaphragm to drop and move more freely, thereby increasing lung volume. A nasal cannula at 15 to 25 liters per minute, no DSAT, during pre-intubation will augment the FRC and assist with oxygenation and CO2 removal. The high-flow cannula also helps to offset dead space and furnishes a small amount of positive pressure. Understanding and optimizing FRC is vital for setting appropriate ventilator parameters, such as PEEP, to prevent lung injury and ensure sufficient ventilation. Understanding pressure is not just necessary, it's paramount, because positive pressure is a fundamental mechanism of modern mechanical ventilation. Depending on the ventilator and ventilation mode, we can ventilate patients based on pressure, volume, or a combination of both. This understanding is crucial for your practice and patient care. Every time you treat with CPAP, report to the receiving facility, and later in your chart, you record the pressure as 5 or 10 centimeters of water. You've documented centimeters of water pressure 1,000 times, but have you ever wondered what that means? Let's look at a little scenario to connect theoretical knowledge to enhance your learning experience. Look at this column of water. Think of each mark as an actual depth of water. Imagine attaching a ventilator circuit to this cylinder and placing the endotracheal tube at a depth of 10 centimeters. In this scenario, you would need at least 10 centimeters of water pressure to overcome the weight of the water and make air bubbles. If you inserted the tube deeper to the 30 centimeter mark, you would require 30 centimeters of water pressure to displace the water. That is precisely how we measure pressure and what the centimeters of water pressure means. How can you do this at home with a cup and a straw? The deeper the straw submerges, the greater the pressure to force bubbling. Airway pressure, PAW, is the pressure within a patient's airways on a mechanical ventilator. Monitoring airway pressure is crucial for ensuring adequate ventilation without causing damage to the patient's lungs. The Hamilton T1 provides clinicians with a pressure waveform that offers valuable insights into the patient's breath-by-breath ventilation status in relation to pressure. The vertical axis of the pressure waveform corresponds to centimeters of water pressure, while the horizontal axis reflects time in seconds. Working from top to bottom, the red line at the top, labeled PAW, conveys you are viewing the pressure waveform and echoes the maximum pressure alarm limit. The T1 prioritizes safety on an enduring basis. To that end, the blue line represents the P limit or pressure limit. The P limit is different from the alarm limit. It is the maximum pressure the T1 will apply before the ventilator terminates the mechanical breath to reduce the possibility of inducing lung injury. Changing the P limit or high pressure alarm limit automatically changes the other parameter. We will explore this principle more when we cover ASV in the next module. Let's look closer at the pressure waveform and the information it provides. The peak airway pressure, P peak or PIP, is the maximum pressure reached during the previous breath cycle. The yellow waveform reaches the peak pressure of 20 and then returns to the PEEP or CPAP of 5. There are two basic kinds of ventilators when we talk about calculating pressure. They are additive and absolute. The Hamilton T1 is an additive ventilator, and I can prove it to you easily. Here we are in a pressure mode of ventilation. My PEEP is 5 and my peak control is 15, making the breath-by-breath peak pressure I deliver to the patient 20. The ventilator adds the PEEP of 5 and the peak control of 15 to make the peak pressure of 20. If I change the PEEP or peak control, it influences my peak pressure. If I make the PEEP 10 and peak control 15, my peak pressure rises to 25. See, the T1 is an additive ventilator. The critical aspects of airway pressure include P-INSP or P-control is the automatically calculated target pressure, additional to PEEP, applied during the inspiratory phase in specific ventilation modes. You can manually set an inspiratory pressure for pressure control ventilation modes such as PCV+, and non-invasive modes such as BiPAP. Mean airway pressure is the absolute pressure in the airways averaged over the entire 1-minute respiratory cycle. Plateau pressure, P-plat. The plateau or end inspiratory pressure is the pressure in the alveoli measured at the end of inspiration when the flow is at or close to zero. The plateau pressure is the gas pressure the alveoli are seeing. On the Hamilton T1, this is a calculation performed by the ventilator on page 3 of the monitoring tab. On some ventilators, the plateau pressure can be measured in a volume mode of ventilation by doing an inspiratory hold. Driving pressure, or delta P, is the pressure required to overcome airway resistance and compliance. The Hamilton calculates driving pressure on page 3 of the monitoring tab by subtracting the PEEP from the plateau pressure. It is a critical parameter because it represents the difference in pressure driving airflow into the lungs during mechanical ventilation. Lower driving pressures, generally less than 15, are associated with better outcomes in patients with ARDS.